Okay, we've now reached the point in which we're going to have a roundtable discussion about some of the presentations that were just given this afternoon, but we can bring in some of the morning talks as well. And so I'm going to invite to come up here at the present time Rosanna Peeling, Patricia Garcia, Mike Cohen, Jamie Blanchard, King Holmes, Michelle Allery, and Hunter Hansfield. Hunter, you need to come up. I have a question for you. We want to probe him. Mike has a meeting he has to attend to. While they're coming up, I wanted to thank all the speakers for outstanding presentations that really have challenged and put down the sort of the roadwork to numerous challenges. And I'm thinking about, as I look at each one touched upon the challenges that they're faced with in trying to achieve success in controlling STIs and HIV. Before we get into the roundtable, I want to personally thank John for the invitation for all of us to be here and putting this symposium together. And that's John's in the back, John Dirks, with the Canada Gairdner Foundation and the awards. We really thank you. This has been extremely well organized and excellent presentations throughout the entire day. In order to make this happen, we also need to thank our sponsors who enabled this symposia. And that's CIHR, Ontario Government, the Federal Government of Canada, OHTN, Ontario HIV Treatment Network, PHO, the Public Health Ontario, and Grand Challenges Canada, as well as other sponsors that have been really very supportive of the entire meeting. Want to also mention that on Thursday, there's presentations that will be given by the awardees, and John Dirks had mentioned that in his opening remarks. And also on Friday, there'll be a presentation looking at, again, HCV and the humanized monoclonal antibodies and protein structures. Is there, John, anything else?
Thanks, sir,
Sorry? Oh, yeah. A special mention to Sarah Devonshire. There she is. Stand up, Sarah. Let's give her a hand. She was the one who put this symposia together and made it really happen. So we're very appreciative of all the work you did, all the emails. It was wonderful. So it was really great. John, anything else? Yeah.
Very interested, and for the speakers, the 5 through 7.
Excellent. And I really want to double that. Thanks to the audience for staying here throughout the entire day and being a part of the whole process. Let me kick this roundtable off. I know Mike's going to have to leave, but a couple things were just said in Jamie's presentation. And I alluded to it to some degree, but didn't go into too much detail. So, Mike, 052, huge success, 96% efficacy, really shows in a randomized trial where you really concentrate on those discordant couples, you can really make a difference in transmission. However, then Jamie put up this slide looking at what's happened in South Africa, that only, 30% who said they were on ART were virally suppressed, something along that. The China study, which was just published in Lancet, also showed a much lower efficacy rate. We've got two things. We've got great randomized trial, shows good effectiveness. The Tanzer study looked like it also was following suit. But then we have the real life, the observational studies, some of the others that are coming along. How do you rectify those?
I think first of all, some perspective is important. I think that with the study he was quoting, and Jamie, let me make sure I'm right, there's a lot of studies from Africa that try and look at, on people provided therapy, what percentage are actually virally suppressed. I think he was saying 70% and not 100% were virally suppressed. Now, 70% is not acceptable, but it's still a pretty high degree of suppression. With respect to observations of discord in couples, which is what most of our data comes from, there are 14 studies, observational studies of discord in couples. Of those, 12 of 14 demonstrate virtually no transmission events. So when it comes to the treatment of an individual in a discordant relationship, it's an unbelievable success. The 2 studies that did not demonstrate success were both in China. And both of them, so the study Jamie cited was a retrospective cross-sectional examination under very adverse conditions that I don't think display what can happen within a discordant relationship. So the discordant relationships are special, but they tell us of the potential, because in the end of the day, all transmission events occur in discordant relationships. There in these relationships, we think what we see as an altruistic behavior, that the people who know they're on treatment and in a special relationship, they probably have a higher degree of viral suppression and efficacy, although we're not 100% sure of that, but certainly in our study, 052, that was true. So what we need to do is roll that out into a more general population event. But this is going to be imperfect. But the imperfection and the logistical challenges, let me cite myself. That's what could be better than that. In a paper that we published today, it ends by saying the logistical challenges are not a reason not to aspire to do the very best you can do. Those are challenges we need to meet, in my opinion.
They're just a continuation on that same topic. With the 052, although you rarely talk about it, it's in all your graphics, and that is, of all your discordant couples, you had 11 that were unlinked, i.e., they went outside of the partnership. And that, I think, is a reflection of real life, and I think we just, in why there may be sort of a justification for why we're doing these combination prevention trials, to actually see if you get treatment throughout the entire community, will it make a difference? Because there is going to be in-migration, out-migration, and it's an issue that needs to be addressed.
Cite your own paper for a second. Tom will cite his own paper that's coming out very soon.
So, we hope it'll be coming out. So we did molecular phylogeny along with sexual diaries in Rakai, Uganda, and there we can find that there's new infections are usually linked to their partner. That finding that Jamie had put up in the Nigeria study, but 30 to 40%, actually it is from the household sexual partner. But 60% were not from that group. In fact, some were outside of the community where fishermen and other high-risk special populations were migrating through and sexual encounters occurred, and there was extraneous introduction of virus to a community where we were scaling up ART. And so it's just something that needs to be addressed. It does reflect real life and how we need to get to that. Yes, very quickly. There you go.
And I think very germane to this, I think also in the African and perhaps the Chinese context, is also the realities of administering ART there, where you may not be fully suppressed, not because you're non-adherent, but because you have a primary resistant isolate, and you're not getting an optimal regimen for your isolate because you don't have resistance testing. You're not getting the appropriate drug regimen for the isolate you have. So we don't know what percentage of these people end up having a resistant isolate and aren't fully suppressed, not because of adherence issues, but because of other issues, and that can only increase. That's the big thing that none of us are talking about. And
WHO, in their new guidelines, has recommended viral load testing to look at that. Mike's going to leave, but because he has an important call he needs to make. But as he walks out, please give him a round of applause. He's probably embarrassed, but I'm going to say he just received, we got notification yesterday, as the top scientists of the state of North Carolina and got special recognition for that. So awards all around. One other thing that Mike had talked about, and then I alluded to as well, is acute HIV, the early HIV, that if we don't capture that, we're going to be missing very high transmissible individuals. And so I'm going to turn to Rosanna Peeling to address how, in diagnostic assays, how should we be addressing capturing that? And while you have the microphone, I wanted you to go a little bit more into detail. I've worked a lot on these diagnostic tests. I really see the biggest obstacle as the market entry, making it through getting the FDA clearances or the European clearances and finally getting it manufactured. Bigger companies buying up these small startups and then blocking their assays and so forth. But I'll let you address this. But I think Mike would feel very strongly. He's been trying to identify acute HIV for the last decade. And so this is a very top priority.
Yeah, we've been working with a number of companies that can measure viral load down to, at least 1,000 copies. But these are not point-of-care instruments still that you could use in villages, right? Mm-hmm. So I think the thing that we need to do is to really provide some incentives for companies that have really good point-of-care technologies or the new chips that we could use to be able to make it so that it's as easy to do as a pregnancy test or as these oral HIV tests. I think that at the moment, even though at home-based testing, although that's a big step forward for FDA to approve home-based testing, it's still an antibody-based test. So we're still missing all the early infections, right? Yeah. The next step would be for us to really get the message out. We need the HIV detection assays that we have now for viral load monitoring to be used for instance testing. I think that needs to be done. And as far as getting companies, small companies into the market, I mean, there are so many issues in terms of knowing where to do clinical trials, getting clinical trial data in every single country you want to market. You know, in the UN family, there are 193 countries. Doing the first point-of-care instrument, Lair had to do 60 trials, 40 of them are in Africa. And how many studies do you have to do to show that the test works? Yeah. I mean, it's a very good test, and you would think after for three to four trials, that's enough data for most countries to approve. But for whatever reason, regulatory authorities are getting much more risk adverse. They are, I think they are, a lot of them are being self-funded, more and more so self-funded. So they're using this opportunity to get some money as well. So it is a big problem. I'm hoping that with the international community, we could do something about that, because patients are denied access, right? And the more trials the companies have to do, the more expensive the final cost of goods will be. And so there has to be humanitarian reasons, you know, the moral imperative for something to be done.
Sheila, you want to make a comment to that?
Even if you had a very sensitive HIV point-of-care test, the period of time of acute HIV infection is so short. How would you roll that out? I mean, would people test themselves every week, every month? Who would be targeted? How would you make those decisions? Maybe this is a question for Jamie, actually.
It is, and Jamie had his hand up, so we'll put him on the spot.
Yeah, I mean, what I was going to say is, I think, you know, I think we have to think really clearly about what these technologies will be used for, right? So if we're thinking about a test for acute HIV infection, so that people can discover that they're HIV positive almost as soon as they've been infected, so that they can get on treatment, that's a very important strategic decision. It will drive the whole agenda in terms of the development of the test. But if it's not going to be practicable, then we're wasting our time and resources, and we're actually grasping at straws from a policy perspective. So I think, what we might think is well, how could the ability to detect acute HIV infection be used strategically? Could we be using this as part of a sentinel surveillance process, or something where we could actually detect clusters of new infections, or where there's a lot of and then we could deploy a combination. So I think we have to, the paradigm that we're thinking, the lens we're thinking about or thinking through for these things will determine what we're trying to develop, on what basis, and how we're going to try to promote it in terms of applications. It's the same thing with discordant couples. If you're saying that your strategy for treatment as prevention is to find discordant couples, that's a very different strategy than saying, what I'm going to do is I'm going to try to saturate communities where there's a lot of HIV. And one may be much more practicable than another. And so we can't sort of say, we've done studies with discordant couples, therefore we're now going to translate the discordant couple strategy to the community if it's not practicable. The concept can be proven in discordant couples, but the application doesn't necessarily need to be discordant couples only.
So at the microphone, please, and then Michelle.
I just wanted to bring this back to Toronto and on a clinician level here in Toronto. And in dealing with large populations in disadvantaged countries, you do have to be looking at all these variables and looking at strategic programming of what you're doing. But for the clinician here in Toronto, it's it's very worrying with the state of our healthcare and richness that we don't have a very good system here. If a couple wants to go and get tested before they start having sex, there is not a very good system to deal with them. And I know that personally, having sent somebody down, and I was so shocked using the clinic that I many years ago actually worked in, the reaction and how they were treated. And so I even went down myself, and I must say, this is quite a number of years ago, I was not impressed. And here was people who are motivated. Now I wonder, I'm wondering if these, as for a North American wealthy market where we now have the morning after pill and we have early pregnancy testing all for home kits, are we at the level to have anything out there for people to do testing who are chronically taking certain risks, men having sex with men in many different partners? We have people going into the bathhouses trying to deal with mental health issues there now. Do we have that? And are we at the point where is it medically safe for the people who have had an exposure, unknown whether the partner is HIV positive and unlikely to find out? Is it safe for that person to take a short course of antiretrovirals? And is that possible to prescribe that? And how could we mobilize that? And I just want to bring out that there is one little statistic that I didn't hear today with the rising levels of HIV. There is, well, at least for STDs, there is a rise in a different cohort, and it is the baby boomers and seniors. And these people aren't used to thinking about all this stuff, but could be educated, but they're not, they would be also candidates for seeking out care if the system was set up in such a way. So although I know this is sort of derailing it from the big global perspective, but if you're really trying to control a major infection, it would seem to be tackling it in all levels and all different social classes and ways people are best treated, which could be different in different communities.
So I can see a number of the panelists would like to address that. I would say my first reaction when you brought that up is you need Patty Garcia and King Holmes to bring their Peru study to here to Toronto, and maybe they can address that. I was very impressed by the behavioral intervention, the mobile health counseling and team The treatment at pharmacies probably could do diagnostics and treatment at the pharmacies and so forth. And so maybe you could address that. I want Michelle also to talk about special populations and how they need to be targeted and counseled, and obviously be approached in a culturally sensitive way where they can access care and treatment appropriately. It sounds like that's not happening in the clinic here.
So if, Tom, if I could make it just a very direct,
Yeah.
very quick comment. You're, to some extent, addressing the issues of translational research and rollout. And translational research can be viewed, type 2, as the behavioral science as it relates to practitioners, health systems, and infrastructures. And probably still not nearly enough behavioral science is addressing those aspects. So how do you get clinics and physicians and so on to do what we all agree they ought to be doing, whether it's screening or proper use of pre-exposure prophylaxis when they get confronted with that, and all of the other strategies we're talking about.
Michelle.
Yeah, okay. So the point I wanted is related to what you asked me to talk about. But, when I talk with national AIDS program directors in some countries, okay, where they have achieved relatively good treatment coverage, they are telling me, when I talk about the new WHO recommendations, that really for them, they don't see how they will be able to implement that on the short term. Okay, clearly not, because in terms of money, of funding they have, and even with the current situation of uncertainty at the Global Fund level, at the level of PEPFAR also, it's not obvious that to go further in terms of treatment expansion than what they are doing now. And they even, with some exceptions, most of the countries, they are more 50, 70% of the target if you consider with the CD4 less than 350. Having said that, one of the possible solutions to implement, the most active combination prevention possible is really linked to program science and to consider the local situation of the epidemic. If we look, the vast majority of the world, the epidemic is driven by core groups. Vast majority of the world. Okay, there's 7 to 10 countries in the east and southern part of Africa that are truly generalized epidemic. But if you look at all the rest of the world, it's either highly concentrated or concentrated epidemics. And, concentrated for me is like, if you look at the analysis we did for the World Bank a few years ago in West Africa, for almost all countries in West Africa, it's 75% plus of HIV cases that are linked to core groups. And if you go to very highly concentrated epidemics, like in many Asian countries, some work we did in India may put it close to 100% of cases linked in some way to core groups. That can be secondary transmission, tertiary transmission, but linked in a way. So new approaches and expanding treatment in many countries, you could start with these populations that are responsible for lots of the transmission. It's sure, with taking into account what Sevgi says, and which is the truth also, is people change their sexual behavior over time. So even the sex worker who got infected, she might not be a sex worker when she's anymore when she's diagnosed. The same thing for men who had been clients of sex workers. 10 years later, they might be in a stable relationship, and that's why we see, when we look on the short term, as such a high proportion of cases that are transmitted within couples. Okay, so you don't want to forget these people, and it's sure that access to testing in general, and maybe when you find the serodiscordant couples, that's probably the second most important population for the treatment if you go in these concentrated epidemics. And the whole issue is to find the right balance and really to understand the local situation of the epidemic. And that will not be the same in the whole country. Nigeria is probably one of the best examples. In Africa, you have some states with clearly generalized epidemic, and some other states that are more like some neighboring country like Mali or Benin at much lower level epidemic. And if you go to India again, you don't never get so higher levels, but the disparity within small geographic areas, you can be at vast amount of variation. And I think is that, and not forget the behavioral component. And when I think about the promotion of condom, okay, it is sure, maybe we have stopped talking so much condom. Maybe people don't talk so much about it now compared to many years ago, because maybe in many cultural contexts, it has been a failure to try to suggest people in stable relationships to use condoms. I think we have not put the message enough that condom use is really the priority in high-risk sex. But maybe, we need to be more subtle in our message about things like condom use. Okay, and because I think we can lose credibility in some way if we say everyone needs to use condom all the time. In Africa, it will never work, because fertility is such an important cultural thing that if you do any action that will decrease fertility, it's a huge problem. And there was that presentation this morning that alluded to fertility issue, this fertility belt, infertility belt that Bob was referring to. It's a real catastrophe for these women there who don't get children in where they are adult. It's really a catastrophe culturally, and these women are highly marginalized, and many of them might end up being sex workers at some point, because it's not so often that you see, and it's not the truth that is so much, at least in the African countries I know, it's rarely very young women who are sex workers. It's very often women who are a bit older, who have been in couples, have been rejected by their husband for one reason or the other, or that their husband died and they were rejected by the family of the husband, things like that. These women are most of the time in between 30 and 40. Okay, so there's lots of things to take into account and it varies a lot from one place to the other. And I think what is the right thing to do is really to adapt what you do in terms of priority and the right balance between the combination, the different components of your combination prevention, to adapt it to the really local situation as well.
And,
So
and Tom,
that
Tom,
certainly does address knowing your epidemic
Yeah.
to the nth degree before you invest your resources in the interventions. Rosanna? And
in
then Patty.
MSM populations in China, when we did a study there and offer free testing and treatment, a lot of them rejected it because they were afraid, because China is one of the countries that you showed as homosexuality is illegal. So they rejected any offer from us because they see us as public health. But in fact, when you interview them, 75% of the MSM in our cohort had gone to the internet and bought HIV tests to test themselves all the time. And so the idea of making the testing widely available to them is important.
Yeah. Patty?
Yeah. My comment was specifically on the issue that we're discussing things that we're doing globally. And we are used to learn from the North, but we can learn from things that happen in the South also. So I think, for example, this idea of trying to expand services through pharmacies could work also in other countries in the North. In London, for example, they are starting a program where they are distributing the day after pill through pharmacies to make it more accessible, less stigmatizing. I don't know, other than what we have done in Peru and now that they are doing in Brazil and some other Latin American countries, of working on STIs with pharmacies. But I think it's an idea that could be taken if we really want to improve the access. But of course, it has to go with issues that legal issues and training, et cetera. The other comment that I want to make is that this opportunity that the point-of-care tests are giving us is to bring the tests where people are going. And so we are working on a model in Peru through the Grand Challenges grant also, to try to see if it's not only counseling, but maybe also point-of-care testing that could be done at pharmacy level, for example. So to try to reach the unreachable, or the ones that will go to the pharmacies to ask for treatment. And I think that's a model that eventually could also be taken within the conditions and within the context. To finalize, I have seen in my last trip to Seattle that there are pharmacies that are offering day care, or I would call it, they are offering medical services without having any appointments. And actually, I think they were offering even STI services, not only for the partners, but I thought that maybe King had something to do with that, because it was kind of like the pharmacy in Peru. So I thought it was interesting. I didn't have time to go in.
It was Matt Golden who got that going.
Oh, he got that ongoing. So I think there are opportunities on the kind of things that we do in one place to try to see if it will work, but it will depend on the context. And that's program science, really.
Right. Speaking of context, this will come back to you, Patty. All of us have shown all these statistics of what's happening in North America with the MSM population. HIV is increasing, syphilis is increasing, gonorrhea, LGV is happening in Europe as well. It's in many, and it seems to be happening in the younger population. It appears to be totally unchecked. The public response has been fairly negligible in terms of what we're doing to mobilize educational, counseling types of issues. If the North could learn from the South, maybe we should be learning what you and King and Jose have done, Jorge, have done in Peru, and somehow get the message much more out there in the public eye that we have a unchecked epidemic still going on. I've always said that the MSM population needs to take hold of this themselves and really be the leaders, the way they were in the 80s and during the activism. But they're like silent on this at this point. And I don't know, I was listening to your presentation, and you said that you had an impact on the women, but not on the men. Have you analyzed why not on the men? Because that's the MSM population primarily, and it's the same issue we're dealing with.
Yeah, and I will start, and then Kim will follow probably. So we're working on that, on the data.
Yeah.
And one of the things that we have seen is that probably men are not seeking health care.
Yeah.
Although they go more, they rarely will go to a health center, okay? They may go to the pharmacy, but still, I mean, what we think is that we push more women to go to the health centers. And actually, we were able to drop prevalence of STDs in female sex workers as low as a women in general population. So, but men are not going to seek care. They may not be going to seek care because they are less symptomatic. That's another thing that we are looking for. And definitely, I think we still have this problem of stigma. Okay, even for men that are MSM, and this is something that is being fighted, a very important number of them, especially when you talk about low socioeconomic groups, they are not registered. Every single person in Peru has a registration card, which is our DNI, that allows us to vote, because we are very proud that we have like levels of voting of 96% of the population, right? Otherwise, you get a fine, so we go and vote. But one of the things is that because they are afraid of going to the office, and because they may have certain attitudes, for example, they may not get their card. And if you don't get card, you cannot go to health centers, you cannot buy things, etc. So it's much more difficult for them to get access. So access is one thing, asymptomatic is another one, and one analysis that we are working on, and King may talk about that, is this treatment cascade to try to see if that could explain why we didn't have any effect on men.
Yeah, it was striking that we hadn't anticipated that the number of women in the random samples of about 4,500 women and 4,500 men that we did twice, that the frequency of attending a pharmacy for complaints related to genital symptoms was 10 times higher in women than in men. They're just, and I don't think that's unusual for Peru. I think it's recognized that women are more medicalized in that sense than men are. Typically, women was for vaginal discharge in Peru. So that point may be a factor. And then I think this treatment cascade that you mentioned, that it got all the attention from I guess it was Gairdner, not Gairdner, but Gairdner, who published this paper a while back on the treatment cascade in HIV, and there are now about 500,000 hits on the website just since that was published a couple of years ago. But it's actually been reported much longer for diseases like TB and other STDs as things to look at. And for chlamydia, this is apropos, Bob and I were talking about this, that of all men who were found to have chlamydia at the end of the study, the proportion of those who actually had symptoms and sought care was just so tiny. It was like 1-2%. The proportion who had symptoms was about 8%. You could argue that maybe those who had symptoms would have gotten treated, and therefore they were not the ones we found at the end of the study. So we looked at the proportion of men who didn't have chlamydia, who had symptoms and who had sought care, and it was very small, so it didn't seem to be the explanation. So that's part of the issue for chlamydial infection and for HIV as well.
Hunter?
As long as we're talking about MSM, I'm curious, a couple of different presentations and slides today refer to the illegality of homosexuality in much of the world and as a potential barrier to prevention. I'm curious, perhaps Jamie first, what's the current state of the understanding of MSM and HIV in Africa, both in terms of their own risks but perhaps more importantly than most of the world, bridging into other populations?
I think countries are. I don't know nearly as much about Africa as many others here. I can tell you there's a contrast in different countries. So we find in Kenya, for example, the National AIDS and STD Control Program is much more proactive in trying to. It's not really even deal with the law itself, but it's really about how the law is enforced or not enforced. It's kind of like sex work laws in different countries. There's a lot of countries that have laws against sex work, but they can do very good programs of mobilization and collectivization and prevention. So Kenya, I think, has tried to take a fairly positivist approach and public health approach to the situation. In Nigeria, people are just scared. The public health people are just kind of scared about what to do. So they don't want to, the HIV and AIDS folks there, I think they're motivated and would like to do something, but they're concerned about their own liability and their own legal peril if they get involved in this, because it's a relatively new thing and there's a lot of sort of conservative attitudes that are coming. So I think in some places they're saying, well, we'll just take a public health approach to it and we'll try to move around it and we'll be proactive. It was the same thing as when we were working in India. But in other places, it can be a real constraint. So I think it differs depending on what the current political scenario is, but it certainly is more difficult. We found it to be more difficult in Africa than in India, and in some cases actually than even working in a place like Pakistan, where for some reason there's more social connections and those kinds of things in the gay community there.
So we have a question. Okay.
Hi, sorry. My name is Simran, and first of all, thank you all for the presentations. It's phenomenal research, and I'm in my first year of university, and I thought I'd check this out, so this was very enlightening. I have one question. So part of the process for addressing HIV and AIDS, through either scaling through scaling up or through any sort of marketing or social campaigns, is like political engagement. So in what way can the scientific community and medical professionals bridge the gap between scientific development and implementation on the ground? So in other words, like engaging with health policy officials.
It's an excellent question. I'm going to turn to Jamie on that one. I sort of was alluding to that some countries just have not scaled up. We know what works. As far as I'm concerned, we're done with doing another randomized trial to see whether PrEP works or doesn't work. We know it works if you take it. But how do you influence policy? And I'll let Jamie take that one on. I
think part of it is I think that you have to be there and stay there. I think I think we quite often think that all we need to do is present the evidence or present the laws from other countries or other kinds of things. And somehow, because we're learned and we've done the research and everything else, they should accept this. But I can tell you that I'm sure that there's been many, many times when I've done exactly that. They politely listened, accepted the received wisdom, and then forgot about it as soon as you left. So I think that where we've been successful, it's where we've actually been engaged and struggled through the problem solving over an extended period of time. I mean, when we were working in India, it didn't happen in the first year, or the second year, or the third year, but after a while, they keep on seeing, you're like the furniture. They kind of start to become a little bit more comfortable and those kinds of things. But I do think that we can't really underestimate the importance of being there for extended periods of time so that you develop that personal level of trust and relationship and those kinds of things. I think that's part of it. I don't think there's a magic way of communicating things or anything else. I think it really does depend a lot on sustained engagement and sustained influence and those kinds of things. And without that, the only other thing I would say is that when you're doing that, you also end up finding sort of potential opinion leaders from within the organization. So for our program on sensitizing police about sex work and MSM and other illegal activities in India, what we did is we ended up finding pretty progressive senior people within the police force, and then we recruited them to be trainers of other policemen. So, but you only really get to know who are the effective people at that if you're there for a while, and you get to not just have professional time, but also even social time with these people.
You know, the key that Jamie and Patty follow in changing policy and engaging people not only in politics, but in virtually all stakeholders in the community is to begin working with them when you begin your program, even during the research phase when you're evaluating an intervention. And then at each step along the way, you try to engage more stakeholders as they come forward. In India, for example, the apparent failure of rolling out HPV vaccine, which is a disaster, was that some young girls died out of thousands given the vaccine. And women's groups who hadn't been engaged in the process came up and said, you can't give this vaccine anymore. It's going to cost tens of thousands of lives because they're not giving the vaccine.
Just a short, we just published, I think 2 months ago or 3 months ago, an article in PLOS. You can find it. It's about the project CISNE, C-I-S-N-E, which is SWAN, which is our implementation project of the rapid syphilis test in Peru. And actually at the end, and I think it's because I thought it was helpful, we put some recommendations on how to go from research to policy to action. And I think the main messages for me is really what Kim was saying, is like, do not wait until you have the results. Engage authorities and engage the community from the very beginning, even from the design of the study. That's one. And the second message is keep them communicated at all times and work with them, the results, the good news and the bad news. And the third one, identify champions. I have to tell you that in a year, we had 376 meetings, okay, with different levels of authorities. So you can say 365 days. So, okay, sometimes we were having meetings early in the morning, and several times I was like going back and forth, but it worked. And I knew it worked when I learned from somebody else that the project was getting an award, but we didn't apply for the award. So it was the region of Callao, the authorities, that applied for the award for their project because they consider that theirs. So that's the kind of thing that should happen.
Yeah, excellent points. Judy? Yeah.
I would just add to all of these comments that, you know, whether you call it program science or implementation science, one of the things that we've got to get better at as public health people and people in medicine or health sciences is looking at broader scientific frameworks. And there is a whole field of policy analysis and stakeholder analysis in which you can actually do systematic mapping at the beginning of who the potential stakeholders are, where they sit, whether they're likely to support or be against what you're trying to do, how important they are as opinion leaders, and then you can strategize, as Patty and King and several of the others were saying, from the beginning, where you're going to put your time and resources to move people along the spectrum of supporting you. And that's as important a part of program science or implementation science as anything else. But, you know, it's something we often don't do at the beginning. And at least in our programs with the University of Washington, we're trying to really focus in a training mode on that piece as well as some of these other components.
Thanks, Judy. So at this point, I've been given the high sign from Sarah. I first want to thank all of you who have stayed all the way to the end, and so you deserve an applause. And I again want to thank all of the speakers from this afternoon, all the chairs of the sessions, and close with the very last remark, and that is congratulations to King Holmes for the receipt of the Gairdner Award in Global Health.
If you can give me the microphone. Just let me thank everybody. I think it's been an exceptional symposium. I think that the participants were brilliant, and I knew many of the folks in the audience, and I think who are also leaders in their own right, and that this is really a program that will have a big impact. I don't know what the impact of making it available on Twitter will be, but hopefully the social media will help in spreading the word. And I think I was interviewed by a reporter who's for the Globe and Mail, I think, and he was saying earlier in the day that this was sort of a little bit depressing about how the challenges were being described. And I said, well, you've got to stick around to hear the stories about how you can really roll these things up. But I think it is amazing how many things have been accomplished. There still are challenges, but we've heard about the amazing progress that's been made in the theory, the framework, the evidence, the implementation, and beginning some of the results. So there's still huge challenges, but I just want to say you were all very kind to me, and it was a wonderful day for me, so thank you. It's really, the inspiring people now are each of you. I know that when one of my fellows in the past came through, Gary Skolnick, his opening remark was, King, please don't get in the way of me. I want to do a lot of research while I'm here. And I think because I've been so inspired by what all you guys are doing, I've decided I'm going to work for another 50 years, but I'm going to try to stay out of your way. So thank you all.